abusive name is brown sugar, but it's a potent and very strong steroidal. It's a steroidal analgesics, morphine, steroidal analgesics. It is widely used for analgesic purpose and pre-operative medications. So morphine, in its chemical structure, there is a presence of two hydroxyl group. If you could remember with catecholamines, during your ANS, catecholamines and non-catecholamines. In catecholamine, all catecholamines generally have a two hydroxyl group. Catechol ring ma testo थियो. So similarly, morphine also has two hydroxyl group in its chemical structure. Presence of hydroxyl group are ionic compounds. If there is a presence of hydroxyl group, then we say that the compound is ionic. Compound is ionic. Similarly, like of adrenaline compare गर्दा morphine लाई भन्छु, morphine बाट compare गरेर अरु drug बुझ्ने हामीले. So similar with the adrenaline. So what was the disadvantage of adrenaline? Adrenaline cannot be given through oral route, high phosphorus metabolism, and low absorption, low distribution, and immediate metabolism. Destruction with gastric acid थुप्रो कुराहरु थियो नि. Similarly, morphine if given means more hydrophilic, lipophobic with your drug that should be lipophilic so that it could easily cross the cell membrane. Same applies here also. Same formula. So morphine being more hydrophilic or lipophobic, being presence of two hydroxyl group in its chemical structure, it has lots of disadvantage. That is, they undergo high phosphorus metabolism through glucuronidation. Their availability and their bioavailability will be very low. The distribution will be also very low. Their availability in the central nervous system will also be very low because their site of action is rather central nervous system than peripheral nervous system or peripheral organs. Because they are central nervous system drug, their availability in the central nervous system should be high so that they can show its mechanism of action, because their receptors, that is mu, kappa and delta receptors, are present in generally especially present in nerve, central nervous system and enteric nervous system also. So morphine if given oral route, complications, more adverse effect on, so that they are not absorbed from GI tract, so they remain in the GI tract and they act more in the GI tract, so resulting in constipation, nausea, vomiting, constipation. So to overcome this problem, there should be some modification in its chemical structure, starting with removal of hydroxyl group. If we could remove these one or two hydroxyl group, then they becomes more lipophilic. Once morphine becomes more lipophilic by the removal of hydroxyl group, now they can be given through oral route. Their availability in the central nervous system would be very high, so that their potency will decrease. That means low dose could give the similar effect. These are the certain things you have to understand. So let me come with other things. Morphine, I think we have already discussed yesterday. The effects, the tolerance, therapeutic use. Now let me come with codeine. Now see codeine. Now try to find the difference between the chemical structure of codeine and morphine. Where is the difference? Codeine we have already studied as an antitussive. Antitussive cough suppressants. Cough for drug treatment of cough, productive, non-productive. Productive expectorant, non-productive was basically given by codeines. Codeine being more abused, that's why they have been replaced by dextromethorphan. Dextromethorphan. So try to find the difference in the chemical structure of morphine and codeine. You have 2 minutes. Go through it. In codeine, there is a presence of methyl group instead of hydroxyl group. Yeah. This presence of hydroxyl, there is a presence of methyl group. Now this changes lots of things for the property of codeine compared to morphine. Difference. That means the drug is going towards more lipophilicity or being more lipophilic because removal of one charge particles or negative charge particles, hydroxyl group being more, now they become more lipophilic. That means now this drug can be given through, oral route. Morphine overcome morphine complications like can be given through oral route. They have better bioavailability and they are also resistant to glucuronidation. Morphine को तपाईलाई याद छ glucuronidation reaction यहाँ हुन्थ्यो दुईटामा, glucuronidation दुईटा hydroxyl group. Since there is no hydroxyl group in codeine, that means they do not undergo, they are resistant to glucuronidation. That means there is less hepatic first pass metabolism for codeine. That means they have low potency. Low dose of potency will give similar effect that is given by morphine. And also their availability in the central nervous system would be high because now they can cross the lipid membrane, especially lipid membranes compared to morphine. This is how you have to understand. It's something you morphine to codeine. So let me come. Change in the methyl group on 3 positions substituted by hydroxyl groups. There is a change. That means now this decreases the dose of morphine codeine to produce same effect that is done by morphine. That means 1/10 the potency for the analgesic property of morphine. They can now absorb readily from the GI tract because being more lipophilicity, the absorption is more regular than morphine and more predictable. Given orally, morphine given through IV routes, generally IV routes, not preferred through oral route. Now metabolized like morphine through glucuronidic acid. यहाँ फेरि complications के तपाईहरु के confusion हुन्छ, glucuronidic acid नै जान्छ तर फर्स्ट पास मेटाबोलिजम किन हुँदैन भन्नुहुन्छ हैन, बिकज त्यो फर्स्ट पास मेटाबोलिजममा के हुन्छ सबै ड्रग त सिधै उसमा जीआई ट्र्याकबाट सिधै लिभरमा जाँदैन नि, 13% जाने हो नि त, त्यसले गर्दा मोर्फिनको अवेलेबिलिटी घटाउने हो नि त। कोडिनको केसमा के हुन्छ, दे आर मोर रेजिस्टेन्स टु ग्लुकुरोनिडिक एसिड कम्पेयर टु मोर्फिन हुँदैन भन्ने हैन, रेजिस्टेन्स चाहिँ ज्यादा हुन्छ, थोरै हुन्छ, यसको रेसियो कम हुन्छ, बिस्तारै हुन्छ, टाइम लिन्छ, टाइम लिने बित्तिकै के हुन्छ फर्स्ट पास मेटाबोलिजम ओभरकम गर्छ भन्ने कुरो हुन्छ है, यसरी बुझ्नुलाई। Then physical dependence is the necessity of drug, so no withdrawal reaction. खाउन्जेल चाहिन्छ, खाइसकेपछि त्यसको withdrawal छैन, just a physical dependence, no psychological dependence. There is no psychological dependence from the codeine compared to morphine. That's why there is no withdrawal reaction, safer compared to morphine. Now tolerance and physical dependence is low from morphine, since potency of codeine is very low because we need to give low dose of codeine to produce similar effect that is given of morphine. That's why the tolerance and physical dependence is also very low, protracted. And this is a antitussive drug for cough, generally not given for analgesic purpose. And we have other better drug compared to codeine, and they have shifted this drug from analgesic to the antitussive because they decreases the threshold of cough center. Antitussive man cough center suppress गर्ने भनेको they increases the threshold of cough center and acts as an antitussive and given for dry cough. Choice of drug given for dry cough, but nowadays being abused, they have been replaced by dextromethorphan. खासै कोडिनको युज आउँदैन है, and they are not available. All these steroidal drugs are not available without prescription. यो चाहिँ कुरा बुझ्नुलाई, any of these कुनै पनि मैले क्लासमा डिस्कस गर्दै थियो, without prescription you are not getting these drugs. Nobody is getting these drugs because they are being abused. I'll come later on. Now comes heroin. Heroin पनि सुन्नुहुन्छ हैन, there was a movie Udta Punjab or something like that. Heroin, white color powder they used to sniff and come. So this is all derived from the morphine. Now heroin, it's also called diacetyl morphine. You could know easily now diacetyl, that means there should be 2 acetyl group in the structure of morphine, one here and one here. Now this becomes heroin. Morphine has 2 hydroxyl group on 3 and 6. Replacement of 1 hydroxyl group becomes codeine, also known as monoacetyl morphine. Monoacetyl morphine or codeine. If both hydroxyl group are replaced by methyl group, now this becomes heroin or diacetyl morphine. Now they are more lipophilic, they are more resistant to glucuronidation. Similar thing, more lipophilic, can cross the blood-brain barrier. Their availability in the central nervous system would be very high. Low dose will produce similar effect compared to codeine and morphine. More superior, they go any drug as a more superior, and they are becoming more. That's why they are being widely abused compared to morphine and codeine. Heroin are being widely abused because of being its central nervous lipophilicity and low potency. So at 3 and 6 hydroxyl position, there are acetyl group instead of hydroxyl group has 3 times the analgesic potency of morphine. Heroin is most lipophilic of all opioids. कहिलेकाहीँ एमसिक्यूजमा सोधिन्छ, यतिकै थाहा हुन्छ, स्ट्रक्चरले थाहा हुन्छ, जसमा चाहिँ हाइड्रोक्सिल ग्रुप कम हुँदै जान्छ त्यो चाहिँ मोर लिपोफिलिसिटी हुन्छ। अब डाइएसिटाइल मोर्फिन भन्ने त कि only 2 हाइड्रोक्सिल ग्रुप, त्यहाँ पनि 2टा एसिटाइल ग्रुप छ भने चाहिँ डाइएसिटाइल। नाउ दे आर द मोस्ट lipophilic of all opioids and morphine is the least lipophilic of all opioids किनभने because they have 2 hydroxyl group, codeine being moderate between बिचमा चाहिँ कोडिन आउँछ है। हेरोइन कोडिन मोर्फिन कोडिन heroin. Heroin more superior, less side effect. Codeine okay medium range, morphine low range. त्यसरी नै बुझ्ने। That's why morphine is a prototype. From morphine, all these drugs are derived, heroin and codeine. That's why heroin and codeine are called semi-synthetic. Right? Parent compound is natural compound, morphine. From there, they have been derived. That's why they are called semi-synthetic. Opioid withdrawal is not fatal in this case. Heroin go with. So when heroin is ingested, okay, it crosses the blood-brain barrier rapidly. Now you know why, because they are more lipophilic, where it is hydrolyzed to monoacetyl morphine. That is hydrolyzed हुँदै जान्छ के हुन्छ, mono diacetyl morphine is hydrolyzed to monoacetyl morphine, that is codeine. It also shows this action, and again it is hydrolyzed to morphine, making more of the drug in the brain, making it 3 times more potent. अब बुझिन्छ यसको जुन मेटाबोलिजम पाथवे छ, एक्टिभ फ्रम टु मोर एक्टिभ भनेर आउँछ नि एउटा बायो ट्रान्सफर्मेसन, एक्टिभ टु मोर एक्टिभ, सेम टेक्स प्लेस हियर। एक्टिभ फर्म हामीले हेरोइन दिने, इट क्रसेस द ब्लड ब्रेन बेरियर, लाइक इन पार्किन्सनिजम भएको छ कि छैन पार्किन्सनिजम क्लास, लेभोडोपा दिन्छ नि, डोपामिनमा कन्भर्ट हुन्छ भनेर, बिकज लेभोडोपा इज मोर लिपोफिलिक। सिमिलर केस अप्लाइड हियर, हेरोइन the most lipophilic now reaches to the central nervous system, where it is again converted into codeine and morphine itself. Its metabolism is त्यसै, that's why their potency is very high. They are more potent, potency low, that's why they are more potent. Low dose will produce, even a smallest dose will produce in maximum effect. This is the superiority of heroin over other 2 drugs, but being more obvious, their availability is very low. अब obvious दिएर यस्तै कुरो भएपछि obvious ज्यादा हुन्छ, obvious ज्यादा भएपछि चलाउन गाह्रो हुन्छ। So withdrawal symptoms of heroin is similar to morphine, but more intense. यहाँ चाहिँ समस्या है, superior भएपछि धेरै कुरा राम्रो हो नि, त्यसको डिसएडभान्टेज पनि ज्यादा हुन्छ। So but more intense, like mydriasis, diarrhea is in instead of constipation. त्यहाँ पहिला के थियो, constipation थियो, heroin it results into diarrhea, vasoconstriction, morphine vasodilation, हैन, due to the release of histamine, morphine results into vasodilation as vasoconstriction. This is adverse है, withdrawal symptoms भनेको है फेरि। and dysphoria means feeling uneasy, हैन, नराम्रो लाग्ने, that is dysphoria, euphoria को opposite. Now there comes synthetic drug. अब पहिला natural compound morphine, semi synthetic compounds heroin and codeine, because they are derived from the parent compound is from morphine, they are made from the morphine, that's why those two were classified as semi synthetic, codeine and heroin. Now come synthetic compounds. Synthetic compounds, they are synthesized in laboratory, their parent structure might not resemble the parent prototype drug, right? Fentanyl, number 1 is fentanyl. Fentanyl structure is entirely different structure than morphine, because they are synthesized in laboratory. It's a synthetic drug. It is 80 to 100 times more potent than morphine. Right? Potent terms are they are rapidly acting drugs, and they are used as pre-operative medications. Short acting, 30 to 45 minutes. Onset of action is within 5 minutes. 5 minutes में काम करते दियो ने। That is very high potency, highly abused, known as China white as a street name. अब ये सबै drug, all the opioids are abused. Most of them are abused. Most and all of them are generally abused. These are fentanyl, meperidine, also called pethidine, also called पेथिडिन यो पनि तपाईले पछि धेरै युजमा आउँछ, तपाईले देख्नुहुन्छ। पेथिडिन produced in 1940s, wanted drug with less addictive liability than morphine. यसरी उसलाई बनाउन खोजिएको थियो, but it has same addictive liability as morphine. No difference with morphine. So they are also being abused. So same CNS action of morphine, sedation, analgesia, respiratory depression, potency same as of morphine, but they do not act as an antitussive. यहाँ चाहिँ काम छ नि यसको, they do not suppress the cough. Tachycardia is seen due to antimuscarinic action, antimuscarinic action हुन्छ, then less histamine release and side effects similar to morphine. अब एउटा morphine prototype पढ्यो भने यसका नि डिफरेन्स थाहा भए पनि हुन्छ है, नथिङ डिफरेन्स है, नथिङ डिफरेन्स, जस्ट दे डु नट सप्रेस द कफ सेन्टर. Unlike morphine, more respiratory depression, more bronchoconstriction, less constipation, no antitussive activity causes mydriasis. Morphine results into meiosis, म्युर कापा र डेल्टा को कुरा आथ्यो यो रिसेप्टर्समा. एन्टिमुस्कारिनिक इफेक्टले के गर्छ, क्यानेल अफ थर्डलाई चाहिँ इन्हिबिट गर्छ, माइड्राइसिस हुन्छ भनेर मैले एउटा पहिला पनि मोर्फिनमा पनि तपाईलाई डिस्कस गरेँ. मोर्फिनले चाहिँ मियोसिस गराउँछ त्यो म्यु रिसेप्टर्स, whereas all these drugs results to mydriasis due to antimuscarinic effect भनेको थिएँ. टक्सिक इफेक्ट सिमिलर टु अट्रोपिन, अट्रोपिनमा आउँछ फेरि अट्रोपिन याद गर्नु, बिकज दे हेभ अ एन्टिमस्कारिनिक एक्टिभिटी, अट्रोपिन बिङ एन्टिमस्कारिनिक, यहाँ चाहिँ रिलेट गर्छ त्यसको एडभर्स इफेक्टले. ड्रग अब्जर्भ ओरली एन्ड इट्स अ ड्रग मोस्टली अब्युज बाई हेल्थ केयर प्रोफेसनल्स ड्यू टु इट्स अभाइलेबिलिटी. है पेथिडिन धेरै पाइन्छ, धेरै चलाउँछन्, त्यसैले हेल्थ केयर पर्सनल्समा चाहिँ धेरै अभाइलेबल भएको कारणले उनीहरूले धेरै अब्युज गर्ने चान्सेस चाहिँ ज्यादा छ यो ड्रगको है यसमा चाहिँ. देन विड्रल इज सिमिलर टु morphine. Now comes methadone. The pharmacological activity is similar to morphine, same potency as of morphine, longer duration of activity. They are observed well orally, whereas morphine can has very low oral availability, 16 to 20 hours duration of action and powerful pain reliever. Methadone पछि यो पनि देख्नुहुन्छ तपाईहरुले, use in maintenance program for narcotic treatment. जो चाहिँ नार्कोटिकमा हुन्छन् अब्युजर्सहरु हुन्छ उनीहरुको लागि चाहिँ मेन्टेनेन्स डोजको लागि चाहिँ दिइन्छ, सो दैट विड्रल वुड बी भेरी लो. विड्रल चाहिँ नहोस् भन्दैछ, विड्रल हुँदैन खासै, दियो भने इफेक्ट डोज घटाउँदै गएपछि त्यसलाई इफेक्ट कम गर्दै 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 गएर चाहिँ एज अ के भन्छ रिह्याब सेन्टर्समा हुन्छ नि, मोर युज इन दोज सेन्टर्स. देयर इज अनदर ड्रग कम्प्लिटली सिन्थेटिक वाइडली युज नाउअडेज because of its abusive potential is very low. यहाँ चाहिँ why it is used because now they are not abused widely because they do not have withdrawal symptoms or psychomimetic actions, or their actions are very low. See, they relieve pain through the opioid as well as other additional mechanism. Affinity to mu, kappa and delta are very low, but they result into analgesic property by inhibition of reuptake of noradrenaline and serotonin. Reuptake यो उसको क्लास भयो कि भएन, डिप्रेसन एन्टिडिप्रेसन्समा आई थिंक भयो होला है. एन्टिडिप्रेसन्समा के पढाउनुहुन्छ, SSRIs भन्ने पढाउनुहुन्छ नि, सेलेक्टिभ सेरोटोनिन रिअपटेक इन्हिबिटर्स, एमिट्रिप्टाइलिन, सर्टाराइन हैन. These drugs similarly tramadol also has a similar mechanism of action. They inhibit the reuptake of noradrenaline and serotonin in the synaptic cleft. So in the synaptic cleft there will be the high concentration of noradrenaline and serotonin, which activates monoaminergic spinal inhibition of pain. यहाँ चाहिँ त्यसले के गर्छ, मोनोएमिनर्जिक स्पाइनल इन्हिबिसन अफ पेन चाहिँ गराउँछ, नट सेन्ट्रल. ओके, स्पाइनल पनि सेन्ट्रली मानिन्छ हैन. सो गुड ओभरबायोलिटी एन्ड वेल टलरेटेड, लेस रेस्पिरेटरी डिप्रेसन because they are not obviously राम्रो किन चाहिँ चलाउन, because they have less respiratory depression, sedation, less urinary retention, risk of intravenous pressure and constipation than morphine. Morphine भन्दा अलि सेफ नै छ, यसको अवेलेबिलिटी पनि हाई छ, क्यान बी गिभन थ्रु ओरल रूट हैन. So it is more superior drug compared to all other opioid analgesics. That's why tramadol is widely used, and it is obviously potential is very low, but it has a risk of serotonin syndrome because they increases the level of serotonin in the synaptic cleft. So should not be combined with contraindicated serotonin, selective serotonin reuptake inhibitors. They should not be combined with SSRIs. Never, tramadol and never are contraindicated with SSRIs. Now comes opioid antagonist. Agonist are Q. Agonist 3 groups. Let me revise: morphine, natural, semi-synthetic, codeine, monoacetyl morphine, and heroin, diacetyl morphine. Morphine structure hydroxyl group, त्यसरी नै थाहा पाउनु त्यसको pharmacokinetic profiles. Dynamic, they act on mu kappa and delta receptor, which are GI coupled. All of the opioid drugs except tramadol. Tramadol has different type of mechanism. Remaining all opioid drugs have similar same mechanism. That is, they are activate, they are agonist to the mu kappa and delta receptors. Mu kappa and delta receptors are inhibitory types of receptors which inhibit the adenyl cyclase. So that they will inhibit the pain pathway. And all opioids except tramadol. Now comes semi-synthetic, fine. Then comes synthetic, methadone, pethidine, and tramadol. Buprenorphine, these are all about opioid and agonist. Now comes antagonist. Antagonists are also classified into 3 different groups. Opioid antagonist, 1 agonist antagonist, that means they have kappa agonist and mu antagonistic action. Kappa ma yo drug le agonistic काम गर्छ है फेरि, but it has a mu antagonist action. 3 drugs available, 1 nalorphine, that's why they are called agonist antagonist. Nalorphine, pentazocine, and butorphanol. It's a butorphanol, a bit difficult to pronounce. Butorphanol. तपाईहरु याद गर्नुपर्ने pentazocine र nalorphine यो चाहिँ अलि चल्छ के. Nalorphine mostly used is always naloxone. I'll come. Then we have partial agonist and antagonist. The drug buprenorphine has partial agonist action on mu receptor and completely antagonistic action on kappa receptor. That's why they are called partial agonist and antagonist. Agonist antagonist हुने बित्तिकै agonist to kappa and mu antagonist. Partial agonist to mu and antagonist to kappa. Whereas we have pure antagonist available 3 drugs. It is wide. This group of drugs are widely used compared to other 3, but also we have pure antagonist to all mu receptors or delta and kappa receptors. That is naloxone, naltrexone, and nalmefene. यो चाहिँ याद गर्नुपर्छ है तपाईहरुले. कहिले सोधिन्छ हामीले ओपोइड अगोनिस्ट मात्र नसोधेर एन्टागोनिस्ट पनि सोधिन्छ है. क्लासिफाई राइट दिस दैट, किन यो केसेस पीबीको केसमा धेरै छ ओपोइड पोइजनिङको केसहरु पनि अभियसली ओपोइडहरुलाई ट्रिटमेन्ट त सोधिहालिन्छ जहिले पनि, त्यो अभियस कुरा हुन्छ. ट्रिटमेन्ट सोध्दाखेरि चाहिँ यहाँ चाहिँ एन्टागोनिस्ट चाहिँ याद गर्नुपर्ने हुन्छ है. Naloxone. Take to come with nalorphine is the first opioid antagonist introduced in 1951. It's a kappa, it's a kappa agonist and mu antagonist. Kappa agonist and mu antagonist. Not used clinically due to dysphoric and psychomimetic action. अब युजै गरिदैन किनभने they have dysphoric नमजा खालको फिलिङ्स हैन. dysphoric जतिखेर नमजा चाहिँ डिप्रेस्ड हुन्छ होला मान्छे धेरै युज गर्यो भने. then psychomimetic action, so psychological actions they are not used nowadays. Comes pentazocine, the analgesic effect due to the agonist action on kappa receptors. Then pentazocine acts as a weak antagonist and partial agonist to mu receptors. The difference with morphine, pentazocine ko analgesic is due to opioid, whereas for morphine basically vomiting is very less, frequency is very high with nausea, vomiting र constipation त लेख्नै पर्छ भने थिएँ मैले हैन. मोर्फिनमा है vomiting is less in case of pentazocine. Sedation and respiratory depression is very less than morphine at low dose. Whereas biliary hepatic biliary pressure पढाउँछ भने चाहिँ morphine similar biliary spasm and constipation is also very less compared to morphine. Tachycardia and raise and blood pressure at high dose, which is less in. Then euphoria at low dose but dysphoric and psychomimetic at higher dose. Whereas morphine has euphoric and psychomimetic in higher dose and low dose, all dose. Then comes pentazocine, also may precipitate withdrawal. Buprenorphine, we have high lipid soluble mu analgesic, 25 times more potent than morphine but very low intrinsic activity. काम छैन, intrinsic activity low हुने काम छैन. So postural hypotension and respiratory depression, sedation, vomiting, pinpoint pupil, serious effect and withdrawal reaction are similar to morphine. त्यसैले morphine प्रोटोटाइप गरेर पढ्नु पर्यो है. अरु सबै ड्रग त्यसै आउँदै जान्छ आफै आउँछ है. इट्स भेरी इजी टु स्टडी ओपोइड्स है. morphine प्रोटोटाइप पढ्ने, स्ट्रक्चरमा ध्यान दिएर त्यसपछि बाँकी सब एगोनिस्टलाई पनि कम्पेयर गर्दै पढ्ने, एन्टागोनिस्टलाई पनि मोर्फिनसँगै कम्पेयर गर्दै पढ्ने, बिकज मोस्ट अफ द एन्टागोनिस्ट आर आइदर अगोनिस्ट एन्टागोनिस्ट or partial agonist antagonist. We have only 3 drugs that is pure antagonist. The pure antagonist को उल्टो effect of morphine लेखिदिने. It's very easy to study. Now we have pure antagonism of morphine. 3 drugs: naloxone, nalfine and naltrexone. They are pure antagonist. अब antagonist भनेको morphine को effect तपाईलाई याद भयो, effects याद भयो, mechanism आफै भने त्यसको opposite effect याद गर्नु कुनै गाह्रो कुरो भएन है. It's very easy. So now let me come with naloxone. No analgesic activity at all because they are antagonists to morphine. They are competitive antagonists at all mu, kappa and sigma receptors. They have high phosphorus metabolism, so given through IV injection displace morphine and other opioids from the receptor side obviously. So reverse all action of opioids and its doses rather quickly, especially in a person on heroin poisoning जो चाहिँ heroin overdose भएर जुन लडिरहेका हुन्छन्. It's very effective because given through IV route, it acts immediately and relieves the effects of heroin. It can cross the blood-brain barrier. Naloxone will also precipitate its own withdrawal, by the way. So naloxone effects are seen in first 5 minutes and only last for 30 minutes later. It's very safe drug. Effect can be seen in first दिने बित्तिकै त्यसले देखाउन थालिहाल्छ immediately. Poisoning case मा overdose र poisoning case भयो भने के हुन्छ, person may die. So in case of morphine or heroin overdose, so if you could administer immediately naloxone through IV route, then the patient might be safe because it acts on first 5 minutes and only lasts for 30 minutes. Within 30 minutes, it will recover. So it increases the blood pressure, metabolized same as a morphine through glucuronidase acid and excreted through kidney. That's its a drug of choice. We have another naltrexone, same effect of naloxone except it is used orally. This is more lipophilic, more lipophilic. So more potent, long duration of activity, 1 to 2 days. Single dose blocks the action of heroin effect for 24 hours. Used for emergency treatment. Right? Then once established, patient given naltrexone. Once, first immediately you have to administer naloxone. So within 30 minutes, what happens? The patient might come into consciousness. So once he comes to consciousness, that is once established, once all the vitals are established, then we go give naltrexone as a maintenance dose because it has a longer duration of action, 1 to 2 days, and blocks the effects of heroin for 24 hours. Right? Immediately naloxone, then as a maintenance dose, naltrexone. Patient get no euphoric effect from heroin, so patient get off heroin, which is also called negative reinforcement. Right? The therapy for post-addict approved for use by FDA and also used for the treatment of alcoholism. यहाँ पनि छ है कहिले nalfine and nalmefene lacks hepatotoxicity. अर्को लास्ट एउटा थियो nalmefene, it lacks hepatotoxicity. पहिला naloxone immediately, then go for naltrexone. यस्तो छ है. Now we have opioid poisoning. यो धेरै सुनिन्छ है, धेरै सुनिन्छ, धेरै देखिन्छ. Most of the widely abused drug in our part of the world, morphine, heroin, हैन, codeine not available. So morphine, codeine also abused, but they are abused in the form of antitussives. Antitussives जुन चाहिँ abuse भएर चाहिँ codeine बन्द गरिएको है. Availability त्यहाँबाट छ. Morphine, we know that it can be available from raw form. In a raw form जुन चाहिँ starting मा मैले एउटा तपाईलाई फिगर देखाएको थिएँ morphine abstraction को, त्यो abstract जुन raw हो, that is called morphine brown sugar भनेको त्यही हो. So त्यही फर्ममा नै त्यो अब्युज हुन्छ. मोस्टली अब्युज त त्यो र फर्ममै हुन्छ, त्यसैले इजिली अवेलेबल र इजिली अब्युज इन र फर्म, द्याट इज मोर्फिन. एन्ड ल्याबोरेटरी सिन्थेसिस के गर्छ, अब अब्युजर्सहरूको काम हो यो सबै. उनीहरूले के गर्छ, आफ्नै ल्याब बनाएर मोर्फिनलाई चाहिँ हेरोइनमा कन्भर्ट गरेर मोर भ्यालुएबल भएपछि मोर इन्कम हुन्छ. यही नै हो मेन प्रोसेस नै है. मोर इजिली अवेलेबल, मोर भ्यालुएबल, मोर इन्कम भन्ने पोइन्टले चाहिँ हेरोइन बनाएर यो दुईटा मोर्फिन र हेरोइन चाहिँ वाइडली अब्युज. अब हामी we healthcare personals, we know about the drug, its effect, but the abusers, they are always they are never aware of the adverse effect or health hazardous effect of morphine and heroin. That's why they take the drug and they also have a tolerance. मैले tolerance को कुरा गरेको थिएँ, morphine मा tolerance हुन्छ, heroin मा पनि tolerance हुन्छ पछि पछि. Tolerance हुनुको मतलब के हो त? Tolerance means to produce same effect of drug there is an increase in dose. अब obviously के गर्दै जान्छ, डोज बढाउँदै जान्छ. They take morphine through IV route, they take heroin through any other route because it's lipid soluble. Everybody knows this. Okay, on the tolerance is the main case for poisoning case. Tolerance develop, they increase dose and at certain point they do not realize that they are on higher dose and at that time a person might suffer from acute opioid toxicity. Symptoms say pinpoint pupils, coma, depressed, respiration strongly suggest opioid poisoning. पहिला अब मान्छे त कस्तो हुन्छ सिडेसनमा हुन्छ त्यो पेसेन्ट देख्नु तपाईले देख्नु भएन पछि देख्नु भने कुनै दिन पेसेन्ट सिड्युस्ड हुन्छ उ सुतेको हुन्छ हैन he or she does not know anything कोमामै भन्नु न स्पेशली एन्ड डिप्रेस्ड रेस्पिरेसन भनेको सास फेर्न चाहिँ गाह्रो भइरहेको हुन्छ है र कसरी थाहा पाउने पिपुल हेरेर थाहा पाउनु पर्यो पिपुल के छ त अब इनिशियली त पेसेन्टलाई हेर्ने बित्तिकै पिपुल चेक गर्नु पर्यो उसको पिन पोइन्ट छ कि छैन इफ द पिपुल्स आर पिन पोइन्ट द्याट मिन्स नाउ इट सजेस्ट द्याट पेसेन्ट इज माइट बी अन ओपोइड पोइजनिङ सास फेर्न सकिरहेन कोमामा छ पिन पोइन्ट छ र कति मान्छे चाहिँ त्यो त्यति नै मर्छन् उठ्दैनन् पनि है ओपोइड पोइजनिङ किनभने त्यो कहाँ को सुतिरहेको चाहिँ थाहा हुँदैन poisoning case that is what all about abuse and poisoning because it is not taken in public place they go to private place they inject those things then they fell in sleep some people might not get wake up utna pani sakदैन because they might die through choking or they might die through coma and respiratory depression any choking पनि हुन्छ कतिलाई है choking भएर चाहिँ बन्द भएर पनि मरिरहेको हुन्छन् अब्युजर because there is a drug results into vomiting यहाँ चाहिँ पुरा intense vomiting constipation vomiting अब सुतेको बेला भमिट भयो चोकिङ भयो हैन रेस्पिरेसन भयो चोकिङ भयो मर्यो त्यसरी पनि मर्छ अरू रेस्पिरेटरी डिप्रेसन कोमामा गएर उठ्दैन पनि रेस्पिरेटरी डिप्रेसनमा पनि मर्छ सो यदि उठिहालेछ भने युरिन फर्मेसन इज भेरी डिप्रेस चेक गर्ने युरिनेसन कस्तो छ फ्रिक्वेन्सी कम बडी टेम्परेचर भेरी लो बिकज पेरिफेरल भेजोडाइलेसन हुन्छ नि सबै हिट लस हुन्छ द स्किन बिकम्स कोल्ड एन्ड कामी द स्केलेटल मसल्स आर फ्ल्यासिड ज रिल्याक्स्ड यसरी थाहा पाउँछ है द टङ मे फल ब्याक एन्ड ब्लक द एयर अर्को समस्या यहाँ चाहिँ पछि सुत्यो थाहा पाएन जिब्रो भित्र गएर ब्लक गरेर मरिहाल्यो उठ्दैन है त्यसरी पनि मर्छ दिस अल अबाउट acute opioid poisoning or toxicity so how do we manage it's very easy we establish patient airway and ventilate the patient obviously this should be done in every poisoning case and drug of choice naloxone अब यहाँ त लाइफ सिधै बचाउनु पर्यो नि उलाई त सो विदिन 5 मिनेट्स काम गर्छ 30 मिनेट्समा त रिभर्स गर्दिहाल्छ एक्सन अफ मोर्फिन सो naloxone the antagonist naloxone is the drug of choice त्यसपछि naltrexone त्यसपछि naltrexone so care should be taken to avoid precipitating withdrawal in dependent patient so the safest approach dilute the standard naloxone dose 0.4 mg and slowly administer it intravenously and monitor arousal and respiratory function त्यही त गर्न सकिन्छ त के गर्न सकिन्छ त सुतेको मान्छेलाई उसको के हुन्छ उठ्न खोजिरहेछ कि उठिरहेछ कि छैन त्यो हेर्ने र उसको रेस्पिरेटरी फंक्सन डिप्रेस हुन्छ सास राम्रोसँग फेरिरहेछ कि छैन त्यो दुईटा हेरियो भने पिन पोइन्ट पुपिल पनि चेक गर्न सकिन्छ है पिपिलले पनि रेस्पिरेटरी फंक्शन्सले चाहिँ वी क्यान सी दैट फर रिभर्सिङ द ओपोइड पोइजनिङ इन चिल्ड्रेन इनिशियल डोज अफ naloxone is 0.01 mg per kg they are all about it then after the patient becomes stabilized we go for naltrexone as a maintenance dose त्यो पनि छ है so this much for opioid all about opioids and opioid related drugs opioids and opioid related drugs opioid सिम्पल छ पढेर एकदम सजिलो छ तपाईले खाली कन्फ्युजन नराख्ने रट्नतिर नलाग्ने भेरी इजी पहिला के गर्ने नेचुरल सेमी सिन्थेटिक सिन्थेटिक एन्ड एन्टागोनिस्ट गर्ने एक्सन बिकज मोस्ट अफ देम आर आइदर अगोनिस्ट एन्टागोनिस्ट or partial agonist antagonist only 3 drugs available as a pure antagonist among them naloxone and naltrexone you have to remember one given for quick relief another is given for maintenance dose naltrexone यति हो सिमिलर अब रिमेनिङ कुरा के हुन्छ इफ यु कुड स्टडी मोर्फिनको प्रोफाइल राम्रोसँग पढ्नुभयो हैन मोर्फिनको चाहिँ राम्रोसँग पढ्नुभयो भने सिन्थेटिक कम्पाउन्ड प्यारेन्ट कम्पाउन्ड त्यसकोलाई आधारमा मानेर तपाईले के गर्नु पर्यो व्हाट यु नीड टु डु इज यु हैव टु स्टडी कोडिन एन्ड मोनोसिटाइल मोर्फिन हेरोइन डायस्टाइल मोर्फिन सेमी सिन्थेटिक फिनिश्ड देन कम्स सिन्थेटिक chemical structure different from morphine but their property is similar almost similar with morphine mechanism all similar with morphine except tramadol which has different kind of mechanism of action you can correlate tramadol with antidepressant drugs selective serotonin reuptake inhibitors त्यहाँबाट थाहा भइहालिन्छ and widely used because they are less abusive if you come to antagonist pure agonist and pure antagonist, agonist, antagonist, partial agonist, antagonist. Antagonist action opposite to, but since they have a property of agonistic action with mu, delta, and sigma receptors, you can correlate these drugs with morphine. Except naloxone and naltrexone, they are being pure antagonists. So all the effects of naloxone and naltrexone would be opposite to that of morphine. द्याट्स इट। यसरी पढ्नु भने एकदम सजिलो हुन्छ। तर धेरै जसो केसमा पर्छ है, अरूमा पनि पर्छ भन्न सकिँदैन, नपर्ला होला है, तर धेरै जसो चाहिँ ओपोइड रिलेटेड केसेस पढ्दाखेरि चाहिँ केसमा चाहिँ आउन सक्छ यो पिबिक्यूमा, किन ओपोइड पोइजनिङ ज्यादा हुन्छ र यो केस बनाउनु पनि सजिलो हुन्छ। सो द्याट्स इट फर टुडे। Have a great Friday, Good Friday. Thank you very much. Anybody, any questions, any queries? I'm still on. छैन, केही छैन, मान्छे छैन कि के हो?
सर त्यो हेड इन्जुरीमा मर्फिन युज गर्दैन किनभने त्यो अलिक क्लियर गर्दैन।
केमा केमा?
त्यो हेड इन्जुरीमा के
मोर्फिन हेड इन्जुरीमा गर्दैन भन्नुभएको?
मोर्फिन इज नट युज, मोर्फिन चाहिँ हेड इन्जुरीमा युज गर्दैन किनभने
यस्तो छ के, यसले के गर्छ, मोर्फिनको सबभन्दा पहिला त के गर्छ, इन्ट्राक्यानल प्रेसरै बढाउँछ है, हेडमा युज गर्ने। अर्को के गर्छ, मोर्फिनले चाहिँ पार्सियल के भन्छ PCO2 पार्सियल कार्बन डाइअक्साइड सेचुरेसनलाई के गराउँछ, रेस्पोन्सिभनेसलाई घटाउँछ नि, त्यसै त रेस्पिरेटरी डिप्रेस हुन्छ, मान्छेले थाहै पाउँदैन। सेन्सिटिभनेस टु PCO2 इज डिक्रिज बाई द युज अफ मोर्फिन। अब के हुन्छ, PCO2 कार्बन डाइअक्साइड अकुमुलेसन ज्यादा हुन्छ तर बडीले चेन्ज गर्न पाउँदैन। बडीले चेन्ज गर्न पाउँदैन भनेर कार्बन डाइअक्साइड ज्यादा अकुमुलेट भयो भने त हेड इन्जुरीमा त प्रब्लम भयो नि, बुझ्नुहुन्छ? अक्सिजन डिमान्ड घटाउँछ नि त। है अनि अर्को के हुन्छ, ब्लड ब्रेन बेरियर पनि क्रस गर्दैन मोर्फिनले धेरै। त्यसैले हेड इन्जुरीमा हुन्छ, सेन्ट्रल नर्भस सिस्टममा ड्रगै जाँदैन, त्यसलाई के दिनु पर्यो, स्पाइनल रुट दिनु पर्यो, दियो भने होइन, नत्र भने त कामै हुँदैन। त्यसको एडभर्स इफेक्ट पनि ज्यादा छ। अब ओरल दिन मिलेन इन्जर्ड पेसेन्टलाई आइभी नै दिनु पर्यो, आइभी दिँदाखेरि फेरि त्यसको के हुन्छ, अभाइलेबिलिटी लो, त्यसले PCO2 रेस्पोन्सिभनेस घटाउने काम गर्छ। अनि त्यसपछि के गर्छ, अटोनोमिक नर्भस सिस्टमको रेस्पोन्सिभनेसलाई घटाउँछ, कार्डियक एक्टिभिटीलाई घटाइदिन्छ। इन्जर्ड पेसेन्टमा त्यो अलिकति इन्ट्राक्यानल प्रेसरहरू बढाउँछ। मेन त PCO2 को कुराहरू गर्नुपर्छ यसमा। त्यसैले चाहिँ यो लेफ्ट अक्युट लेफ्ट भेन्टिकुलर फेलियरमा चाहिँ ड्रग अफ चोइस हुन्छ। फेरि सेम रिजनले चाहिँ यता फेल यता दिनु हुँदैन भने सेम रिजनले चाहिँ यता लेफ्ट भेन्टिकुलर फेलियरमा चाहिँ त्यो हार्टलाई चाहिँ कार्डियो प्रोटेक्टिभ रोल हुन्छ कि, त्यो चाहिँ भेन्टिकुलर फेलियरमा चाहिँ मोर्फिन चाहिँ इमिडिएटली एडमिनिस्ट्रेट गरिन्छ। दुईटाले याद गर्नु नि
सर। सर न्यालोक्सोनमा के अरे प्रिसिपिटेट्स विथड्रल भने विथड्रल कसरी प्रिसिपिटेट गर्छ सर न्यालोक्सोनले?
जब विथड्र हुन्छ तपाईँ न्यालोक्सोन जब विथड्र हुन्छ, न्यालोक्सोन विथड्र हुने बित्तिकै इन्टेलिजेन्स ओपोइडले फेरि त्यहाँबाट काम गर्छ नि त। हाम्रो शरीरमा त अलरेडी इन्डोर्फिन डाइनोर्फिनहरू त हुन्छ नि त, त्यो पनि त ब्लक भएको हुन्छ इफेक्ट होइन। मोर्फिनलाई रिप्लेस गर्छ, फाइन, मोर्फिनको काम हुन दिएन। तर जब न्यालोक्सोन आफू पनि रिप्लेस हुन्छ, फेरि इन्टेलिजेन्सले आएर काम गर्छ, अथवा मोर्फिनको कन्सन्ट्रेसन अब कति अमाउन्टमा छ त्यो फेरि आएर काम गर्न सक्छ भनेर हो त। न्यालोक्सोन आफूले त गर्दैन, उसले त वाइन अफ गर्ने हो त्यो इफेक्टलाई होइन, युफेटिक इफेक्टलाई। तर के भन्छ, सर्ट ड्युरेसनमा काम गर्छ नि, जम्मा 5 मिनट 30 मिनटमा मात्र काम गर्छ न्यालोक्सोन त, 30 मिनटसम्म मात्र गर्ने हो। त्यसपछि त्यो त्यतिकै 30 मिनटमा त मोर्फिनको त हट्दैन नि शरीरबाट, अभेलेबिलिटी त हुन्छ नि मोर्फिन त अलरेडी होइन। त्यसले पेसेन्टलाई मोनिटर गर्नुपर्छ, दिँदै जानुपर्छ, अराउज भयो अथवा स्टेबलाइज हुँदैन बल्ल न्यालोट्रेक्सन जानुपर्छ। ठिक छ,
हजुर सर, थ्याङ्क यू सर।
Okay, that's it.